Chest pain. To help determine the cause of chest pain, it is important to ascertain the duration, location, quality, and precipitating and aggravating factors, the four cardinal features, as well as means of relief and accompanying symptoms. Angina comes from the Latin word meaning choking, and the patient may complain of crushing pain, heaviness, discomfort, or a choking sensation in the retrosternal area or in the throat. It is best to ask if the patient experiences chest discomfort rather than pain, because angina is often dull and aching in character and may not be perceived as pain. The pain or discomfort is usually central rather than left-sided. The patient may dismiss his or her pain as non-cardiac because it is not felt over the heart on the left side. It may radiate to the jaw or to the arms, but very rarely travels below the umbilicus. The severity of the pain varies. Angina characteristically occurs with exertion, with rapid relief once the patient rests or slows down. The amount of exertion necessary to produce the pain may be predictable to the patient. A change in the pattern of onset of previously stable angina must be taken very seriously. Although angina typically occurs on exertion, it may also occur at rest or wake a patient from sleep. Ischemic chest pain is usually unaffected by respiration. The use of sublingual nitrates characteristically brings relief within a couple of minutes, but this is not specific as nitrates may also relieve esophageal spasm and also have a pronounced placebo effect. The pain of myocardial infarction often comes on at rest, is usually more severe and lasts much longer. Pain present for more than half an hour is more likely to be due to myocardial infarction than to angina, but pain present continuously for many days is unlikely to be either. Associated symptoms of myocardial infarction include dyspnea, sweating, anxiety, nausea, and faintness. Chest pain made worse by inspiration is called pleuritic pain. This may be due to pleurisy or pericarditis. This pain is not usually brought on by exertion and is often relieved by sitting up and leaning forwards. It is caused by the movement of inflamed pleural or pericardial surfaces on one another. Chest wall pain is usually localized to a small area of the chest wall, is sharp and is associated with respiration or movement of the shoulders rather than with exertion. It may last only a few seconds or be present for prolonged periods. Disease of the cervical or upper thoracic spine may also cause pain associated with movement. This pain tends to radiate around from the back towards the front of the chest. Pain due to a dissecting aneurysm of the aorta is usually very severe and may be described as tearing. This pain is usually greatest at the moment of onset and radiates to the back. These three features, quality, rapid onset, and radiation, are very specific for aortic dissection. A history of hypertension or of a connective tissue disorder such as Marfan's syndrome or Ehlers-Danlos syndrome puts the patient at increased risk of this condition. Massive pulmonary embolism causes pain of very sudden onset which may be retrosternal and associated with collapse, dyspnea, and cyanosis. It is often pleuritic, but can be identical to anginal pain, especially if associated with right ventricular ischemia. Spontaneous pneumothorax may result in pain and severe dyspnea. The pain is sharp and localized to one part of the chest. Gastroesophageal reflux can quite commonly cause angina-like pain without heartburn. It is important to remember that these two relatively common conditions may coexist. Esophageal spasm may cause retrosternal chest pain or discomfort and can be quite difficult to distinguish from angina, but is rare. The pain may come on after eating or drinking hot or cold fluids, may be associated with dysphagia, difficulty swallowing, and may be relieved by nitrates. Cholecystitis can cause chest pain and be confused with myocardial infarction. Right upper quadrant abdominal tenderness is usually present. Causes of chest pain. Cardiac pain. Myocardial ischemia or infarction. Vascular pain. aortic dissection, aortic aneurysm, pleuropericardial pain, pericarditis, infective pleurisy, pneumothorax, pneumonia, autoimmune disease, mesothelioma, metastatic tumor, chest wall pain, persistent cough, muscular strains, trauma, intercostal myositis, thoracic herpes zoster, Coxsackie B infection, thoracic nerve compression or infiltration, rib fracture, rib tumor, primary or metastatic, Tietze syndrome, slipping rib syndrome, gastrointestinal pain, gastroesophageal reflux, common, esophageal spasm, rare, airway pain, tracheitis, intubation, central bronchial carcinoma, inhaled foreign body, mediastinal pain, inhaled foreign body, mediastinal pain, esophageal spasm, esophagitis, mediastinitis, sarcoid adenopathy, lymphoma. Chest pain due to respiratory disease is usually different from that associated with myocardial ischemia. The pleura and central airways have pain fibers and may be the source of respiratory pain. Pleural pain is characteristically pleuritic in nature, sharp and made worse by deep inspiration and coughing. It is typically localized to one area of the chest. It may be of sudden onset in patients with lobar pneumonia, pulmonary embolism and infarction or pneumothorax, and is often associated with dyspnea. The sudden onset of pleuritic chest pain and dyspnea is an urgent diagnostic problem, as all three of these conditions may be life-threatening if not treated promptly.